The first one is, and your very elegant comments about transplantation now with the integration of novel agents. But how do you choose in practice who should go to transplant and who perhaps isn't going right away?
Well, we at least will encourage everybody, if they're unenthusiastic, well, obviously if you have an unenthusiastic patient, we don't make them have a transplant, but we will recommend they have a collect and store. So we treat to best response, and with the use of these drugs such as plerixafor combined with GCSF, we can store and put those cells away, and then save it for later, for a future transplant as necessary, since the majority of patients will have progressive disease. We also recommend for high-risk patients, if they've got high-risk features, they're going to be the ones that we're thinking about offering transplant early, especially if they're young and fit. As we get into an older age population, then it's more of a clinical decision between the patient and their physician. So we don't recommend it for everyone, but at least based on the current data, we think it's still part of the standard. And that is a great segue into the next slide, which shows that this is your study with, that's being led by Paul Richardson. And these are transplant-eligible patients who are being studied in both France and in the US. And they receive an RVD induction for 3 cycles. They receive a cyclophosphamide mobilization, and stem cells are stored for both arms. For the non-transplant or the transplant later arm, they receive more RVD for 5 cycles and then lenalidomide maintenance. And there's a difference between France and the US I'll discuss in a second. The other arm receives melphalan transplant followed by RVD ×2 and then len maintenance. In the US, 600 patients will receive lenalidomide until progression. In France, they'll receive lenalidomide only for a year. So, and I know your group is studying a lot of these in quite molecular detail. So we're going to learn a lot. So we'll be able to tell who can wait, who may even never need a transplant.
So can I ask, there's another question which again is exactly what you're addressing here, but outside of the context of a clinical trial, how do you choose who should go on maintenance therapy? Are there patients who don't go on maintenance therapy?
Right now we recommend, since the data showed that both CR and non-CR patients, as well as those who receive len induction and not, benefit, we usually will offer it to them. If we have somebody who's very high risk, has deletion 17, 1Q and 1P abnormalities, multiple abnormalities, then we will often recommend combining, adding a proteasome inhibitor in low dose, say every twice a month, along with lenalidomide. Now that's not in the context of a clinical trial, and that is a bit of an off-label use, as is all of maintenance, because right now we don't have an FDA-approved indication. But we're thinking about this in all of our patient populations based on the CLGB results. Now I think the French bring up other results that cause us to have pause, and I think there it's because half of their patients got VAD, they only got bortezomib dex as induction otherwise, they didn't get an IMiD, and they also got a lot more alkylator therapy. So those, I'm more concerned. So I think if a patient's been beat up with a lot of prior therapy, I may be a little bit more leery. But often the ones who are beat up with a lot of more prior therapy are the ones who need to have their disease control. So it's sort of a risk-benefit. So I'm thinking about it in all our patient populations for trying to control disease, especially since we have such great drugs as salvage regimens.
Very nice.
So I'm going to close with a few more slides. And this is the current U.S. cooperative group strategy. This is kindly provided by Vincent Rajkumar. The studies at the top are those that have finished, looking at, in the old studies, RD versus VRD. MPT versus MPR was just looked at and presented at ASCO. We have studies that are ongoing at the bottom, ranging from smoldering myeloma. There'll be an alliance study looking at plasmacytoma. We have a high-risk study using elotuzumab, as well as other studies through the BMTC10. There's a vaccine study out of out of Beth Israel. David Avigan's leading that, looking at a dendritic cell vaccine with lenalidomide versus lenalidomide. And there's also going to be a high-risk allo protocol. And there's a variety of different strategies looking for control of disease after relapse. So I'll make this real quick. We're thinking of well-tolerated induction regimens for the transplant eligible, usually a triple; for the transplant ineligible, a doublet. A single transplant is standard and potentially a transplant later after collection of stem cells. Consolidation is reasonable, more in Europe than the US. And we're always thinking of some type of maintenance strategy, usually with lenalidomide, possibly with bortezomib with controlling disease long term. We need better risk stratification, incorporating of newer agents. We need to standardize MRD measurements. We need disease control with less toxicity, and identify new target pathways for testing new agents. So I'll go through this quick. This is from the ASH education session, where we're thinking about for the transplant ineligible RD, the other alkylator-based and the imidase therapies aren't dead yet, but there's some data showing that VMP is better than VTP. The idea of continued therapy. We have emerging new regimens and incorporating these new agents up front, such as carfilzomib and pomalidomide. For now, transplant continues. We have both len and bortezomib for continued therapy afterwards, and we have the concept now of len-dex until progression for the non-transplant eligible patients. I'd like to thank all my collaborators in the CLGB, my colleagues, in particular the patients who participated in the CLGB study. And I'd like to put in a pitch for the 15th International Myeloma Workshop, which will be in September of 2015. And I'd like to thank you all very much.
Phil, that was fantastic, and I do want to also emphasize the international workshop in Rome that's coming up. It will reflect even more excitement than we have here. We have one other question here that I think is really prescient. What do you think of in terms of the newly diagnosed patients? What is the most acute unmet medical need for newly diagnosed patients?
I think it's still the idea that we're still thinking of control and not cure. I think that's the bottom line, and we need to develop, and whether that's better drugs, different strategies. So for example, I can remember one of our colleagues at the Dana-Farber talked about diabetes as a incurable disease and you can control it forever. And if we can look at myeloma that way as diabetes, that it's something that you don't necessarily have to cure, but you can control forever, that's a pretty good trade-off. So I think that I consider is the biggest unmet need is long-term disease control or even cure.
And then one that I just ask you, but now that we have such effective agents, especially in combinations, you mentioned beautifully the minimal residual disease goal. There's been a controversy over the years of should we try to achieve minimal residual disease, or is response that important, or is disease control and making myeloma a chronic disease enough? Do you have any comments on that?
I like both. I mean, I think you can make it a chronic disease, but I'd rather have it a chronic disease that's MRD negative. That's my feeling, because I think the Spanish and the British have shown very nicely that patients who achieve MRD negativity have better disease control in the long run. It's just how do you get there? What's the best strategy? And not beating up your patient too much to get there.
Yeah, couldn't agree more. And I think we've learned from the allogeneic transplant trials that you and others have conducted that MRD negativity in the allograft recipients does portend for long-term disease-free survival. So won't it be exciting if we can do that in the patient, him or herself?
Absolutely. To me, if we don't have to do allotransplant anymore, I'm fine with that. We really need to have a strategy that allows us, the patient themselves, to be able to control their disease through help with the medications we administered. And I'm very excited about immune approaches that allow the patient's own immune system to target and eradicate disease.
Yeah, it's clearly the immune therapies are probably the most exciting new area in myeloma, in cancer in general, and I do think it's happening in myeloma. I will have some comments to that effect for sure. It's been decades that we've been waiting for that
Yes.
promise. But novel agents of many kinds, immune therapies, evaluating now the role of stem cell transplant and maintenance, it's really a most exciting time in terms of multiple myeloma.
Absolutely, Ken. I can remember when I started back in the 80s, the median survival was 3 years. And now the median survival is bumping up on 10 years, and that's really pretty amazing.
Well, you know, and I'll just allude, there was a recent experience in the Journal of Clinical Oncology where the lenalidomide bortezomib dex by the French, induction followed by transplant, using the same regimen for consolidation and then lenalidomide maintenance. The follow-up is short, it's only 3 or 4 years, but hardly anyone's relapsed. And about 2/3 of the patients are MRD negative. So we're really getting to a chronic illness with even MRD negativity. I do think curative potential is on the horizon.